explaining one specific case, a chronic low back pain with leg pain case, where I was able to use, and the review of the imaging really helped with my clinical decision making. And it also helped me to really inform my prognosis for returning to certain functional tasks. So make sure that you're always reviewing the imaging. Sometimes it can be relevant and sometimes it cannot. So it's important to actually take a look, see what the report says, look at the images yourself so that you can get a picture of really what's going on, and then communicate with the radiologist if you're not sure. So we'll go ahead and get started here. So this case was a 35-year-old female, normal BMI. She's fit, healthy, otherwise no other significant medical history, and a non-smoker. Her occupation, she's a school counselor and a former collegiate soccer athlete. So we're talking somebody who definitely had a good athletic background. Her chief complaint was low back pain and leg pain, where the back pain was exceeding the leg pain at the time. This has been intermittent for about 12 years. And the way that it started, the original mechanism of injury, I'll explain. So she explained that when she was in college playing soccer, she had a little bit of back pain, but then stopped playing soccer for an unrelated reason, and that back pain seemed to resolve. A few years later, she was playing recreational soccer, and she reported just waking up after a game or a practice or something and feeling like she couldn't bear weight on that left leg. Pain in the leg exceeded pain in the back. Because she couldn't bear weight and felt weakness in the leg, she went to the ED. The ED, took a look at everything and then made a referral to orthopedics. Orthopedics evaluated her, and because of the neuroscience, they referred her to a neurosurgeon. The neurosurgeon, when she first evaluated her, they did an epidural steroid injection just to try to calm down the hotness that was taking place there. And then they also did a Medrol dose pack and just tried to, let it ride out, see if it would conservatively recover. But over a 3-week period of time, she had some progressive weakness in that leg, and in that myotomal distribution. So they proceeded with a microdiscectomy at the time at the L5S1 level. And then she had pretty good symptom resolution from that, did some post-op physical therapy. And the only thing that was lingering was a little bit of residual lower extremity sensation loss. She did have another episode, unfortunately, 3 years later, from a bending, like sort of bending and reaching mechanism. The symptoms came back, and at that time, she was offered an elective microdiscectomy, to which she proceeded. And after that episode, she had pretty good symptom resolution again. And between the time that she had that second microdiscectomy to the time that she saw me was probably like 8 years. And during the 8 years, she had some periodic back pain here and there, but nothing for which she sought long-term care, no therapy during that time. So when she came to me, she had been having back pain more than leg pain for about 8 weeks. The back pain was constant at like a 2 out of 4 or 2 to 4 out of 10 intensity. And then also she was having some jolts, or like what some of those patients would describe as like the lightning strike in the leg, or like, the sharp stabbing pain with certain movements and positions. Aggravating factors were bending and lifting. So she has some little kids, and she bending and like lifting up the 2-year-old was definitely provoking her symptoms. And then any prolonged sitting or standing for an extended period of time. Standing was even like 1 to 2 minutes before she noticed an additional amount of symptoms. For easing factors, walking, movement, those types of things were really helpful. And then also laying on her back. In the physical exam, she had normal vitals, which everybody should be checking vitals, right? We all need to check vitals as part of our regular routine practice. So normal vitals, which is a great sign, and also no cardiovascular risk factors that I could see or take note of. She did have reduced sensation and reflexes in that L5S1 distribution, which was expected. And sometimes that lingers, for a long time, even if you're not symptomatic after having, really hot radiculitis like this. And she had limitation in the lumbar range of motion, with extension more limited than flexion. With flexion, she was just more fearful of the flexion movement because she associated with bending and flexing with, hey, that's what's going to make my disc messed up. So again, we'll talk, fear is like a whole nother component that we'll talk about, but she had reproduced symptoms with the slump, but that doesn't necessarily mean that she had, you know, a radiculopathy at that time. I honestly think she had a difference, a right to left difference in that slump test, because of neural contracture, really, you know, because those neural tissues and then all the surrounding connective tissue and myofascial tissue is probably a lot shorter over a period of time, especially after having a number of surgeries. And this was reinforced by looking at her hip. She had really significant loss of left hip extension, I like 15 degrees plus from neutral. So when I'm looking at radiographs, when I'm looking at imaging for a patient, I usually start with the radiographs just to give me an idea of what's the normal kind of bony alignment of the patient. Now, keep in mind, a lot of times they're taking radiographs of different body parts. They'll take a lot of them in supine. So you have to be aware of, okay, this person might have had this image done when they were in this position, but how is their body changing when they change positions or go into a standing position or otherwise. So I always start with the neutral, and hopefully you can see my mouse here. So I just kind of look at all of the vertebral bodies. And then another thing that I start looking at, I'm looking at the neutral image right now. So the one thing that I am looking at is the space that's in between the vertebral bodies. So that's basically telling you how much disc height there is in this particular patient. So start from the sacrum and sort of work your way up so you know what level you're at. So here we have L5, L4, 3, 2, 1, and so on. And interesting note here is we know that this particular patient had the discectomies at L5S1. So if you look, you can even just tell right with the neutral view that there's a substantial amount of disc height loss at that level, which sometimes in older patients or, in patients who just have like generalized low back pain, they might have an image where like every single disc space looks like that. And that could just be an incidental finding. You know, that's kind of maybe part of normal aging. But in this particular circumstance, I mean, she's probably got 2/3 lost disc height space at this L5S1 level in comparison to the other levels. Another thing that I'm looking at is this intervertebral foramen. That's where the nerves are going to be, the exiting nerve roots are going to be coming out and going into the lower extremities, you know, contributing to that lumbosacral plexus and then going down into the sciatic nerve. Or going into the abdomen and, you know, forming into the femoral nerve, the genitofemoral nerve, etc. So you see really good intervertebral foraminal spaces in kind of these levels. And then you get down to this level on the bottom, and we don't have a whole lot of space that we're working with there, just even as a baseline neutral image. She also has just the slightest bit of retrolisthesis, just the tiniest little bit of L5 on S1. So when we go and look at the flexion extension views here, then in the flexion view, I'm really not seeing a whole lot of change. But also one thing that I notice, and I'm able to compare because I'm the clinician and I actually did a physical exam on this patient, whereas the radiologist who's looking at this doesn't necessarily have that same information. But I know that she was fearful of flexion to begin with. So her flexion in this view is very limited, especially at the lumbar spine. So when I'm looking at this, I'm already like, okay, well, there's not a whole lot of lumbar flexion that's even taking place in this picture anyway. So I would expect that at the L5S1 level, it's going to look pretty much the same as neutral. Now, the extension view, on the other hand, is starting to paint a little bit of a picture for me. So she actually, you can tell definitely that there is some legitimate lumbar extension taking place here. But again, look at those intervertebral foraminal spaces. And then down here, not only is there a loss, like a significant loss of what already is really small spacing there, but you're also seeing some bony approximation between the posterior aspect of the vertebral body of L5 and S1. So they're actually kind of approximating in that position. So in a normal circumstance, if this patient extends, she might be having bony abutment, actual bony approximation, and she also might be encroaching those nerve roots that are still there. So I start with the radiographs, and then I move into the MRI just to kind of see. I really like to look at tissue quality, and I really like to look at the actual disc fluid levels. So I'm going to move on to that in just a moment here. So I like to start with the sagittal views. The sagittal views, it's really easy to see. It sort of looks like the side of a spine and what you would expect in like a spinal model. So when I start out looking at lumbar MRIs, I look at if I'm specifically looking for disc stuff, I look at the sagittal T2, because the T2 weighted images are going to be where fluid is bright. And where you see this stuff is all cerebrospinal fluid. We can see the conus medullaris ending right there, right where it's supposed to end, right around that like L1, L2 level. And then all of this stuff is just cauda equina surrounded by cerebrospinal fluid. So those T2 weighted images are going to show where the fluid is bright. So then I start looking at the discs. So I look here and I look here and I'm like, okay, there's a little bit of brightness there, a little bit of brightness here, a little bit of brightness here. So we can tell that those discs have good fluid properties just based on, what those hydrogen protons are doing in the MRI machine. And they pop out whenever they're present. So then we see L4, L5 still have really good spacing, but it's a little dark. So, it is what it is. Little dark, just meaning there's just a little bit less fluid quality, and maybe that's just what it is at that time of day. But then when I start looking at L5S1 again, I see a little bit of that retrolisthesis. I see definitely, probably a good 2/3 loss of the height of the other discs above. And then I also see just a little bit of bulging protrusion. Again, to me, not concerned about that. Looks a little normal. My biggest thing is, since I know that she had 2 microdiscectomies, there's already so much of that disc material that is lost and it's not coming back. So once you go in, it's like in the knee meniscectomies. Once you start removing meniscus material, it's not coming back. So those two things they can be very analogous, and you have to be concerned about what's going to happen to the bony structures and to the nerve structures that need room and space. So that's the look of the sagittal view. Then a lot of people skip looking at the axial view, and I'll tell you why you shouldn't. So here is the axial views here. And I wanted to do a comparison where I'm showing you the difference between her L5S1 versus her L4, L5. So just the difference in one level. The first thing that I look at, because I think this is one of the things that's most clinically relevant, is actually the muscular tissue quality. So we can see here, these are actually going to be the lumbar paraspinal muscles, okay? And so those are our loins, if you will. And you can see that at this level, so here is the spinous process, here's the central canal, vertebral body. And you can see here that there is, I would say, a mild to moderate amount of, what we call marbling, or it's really fatty deposition. So with disuse atrophy in these deep lumbar muscles, sometimes this will take place, this disuse atrophy, and once it's there, it's not really reversible. So I am going to be sharing another case where I talk specifically, or I talk a little bit more in detail about muscle tissue quality and why it's important to evaluate and look at it and inform prognosis. But another thing I just want to let you know is, like, this is one level below and this is the level above. There's a decent difference. I mean, she has excellent tissue quality here, but there's just a little bit more marbling going on, especially in those deep lumbar layers, which we know those are somehow tied to patients that have chronic and persistent low back pain. So other things I'm looking for in the axial views, I'm certainly looking to see if there's any central cord compression. Now we're at the real low levels of the spine, so this is all cauda equina. But if it were higher, if it were in the thoracic or cervical spine, I would definitely be looking to see if there's any central cord compression, which is obviously a problem, central stenosis just from osteophytes and other bony buildup. And then and this is harder to see right now, but any actual nerve root encroachment. And that would be something where on the MRI, you're actually kind of scrolling through up and down to see where those nerve roots are. So this is just a really good way. I hope that this was helpful. I think this was a really good way for me to explain how I use imaging to inform my prognosis. And my prognosis for this patient is actually very good, but I know now, and I sort of tested it in my interactions with the patient. I know that she doesn't respond to extension well. Whether I do lumbar PA mobilizations or whether I do this and that, she has not been able to regain that extension. But the imaging kind of paints that perfect picture for me, right? Because I could see the bony abutment actually taking place, and that reduction in the interforaminal spaces. I mean, it was quite obvious. So if you put those clinical pieces from your clinical exam and your work with the patient together with the imaging, it really complements one another. And in other cases, sometimes their imaging could look really, really bad, but they progress really well in the clinic. And in that case, sometimes there's stuff on imaging that's just like wrinkles on the skin. You know, it's incidental, it's benign, it's not part of their specific problem, but a lot of times it is. So my whole guidance to you would be, make sure if they've had imaging done, or if you've ordered imaging yourself, that you're actually reviewing it, that you understand it yourself, and that you are educating the patient appropriately in a way that is not going to incite fear or instill this sort of like, fear-mongering behavior where they're like, oh, that's what my back looks like, I shouldn't do this and that. And I'll reserve some other videos for how we actually talk to our patients about imaging, so that we're not oh, you have an 80-year-old spine. Like, come on, guys. You use your words carefully. But I'll save that for another time. I hope this was super helpful, and let me know if you have any questions. Reach out to me at any time, info@redefinehealthed.com.